Okay, so your MRI looks normal, but you've still got horrific back pain. Why is that? So, familiar scenario. You have back injury, you go and see a health professional, so it could be a physio, doctor, whatever it may be, and they say, right, first things first, let's go and send you off for an MRI and see what's going on with your back. You wait a week or so for the results to come back, have your next meeting, they pull out the MRI, and they say, well, as far as I can see, your MRI looks normal, I don't really know why you've got back pain. Well, you know you've got back pain because you've got back pain, so what could it be if it's something that's going to be on the MRI? Well, what we need to do is we need to understand that we have basically three subsystems from the Panjabi model that need to interact and work together correctly for us to have a strong, stable and pain-free lower back. Those three subsystems are neurological, passive and active. Quite often when people talk about back pain, they'll focus on the passive system, which is the vertebrae, so the bones, the discs and potentially the ligaments. Particularly the discs, people will sort of just zone straight into, you've got back pain, it's probably a disc bulge or a herniation or an annular tear or something like that, which would show itself on an MRI. But again, that's not the reason why you might have pain, because there could be some issues with the neurological or the active systems. And I'll give you an example. So say you have an MRI and you do have a disc bulge or a herniation. We know those disc bulges and herniations are caused by repeated mechanical hydraulic pressure from overuse of flexion or loaded flexion. So one of the ways that we can get that disc bulge or herniation to retreat and heal is we can use passive extensions. So something like a disc recovery position can work quite well for people, and it will just help heal that disc bulge. Here's an example of one that healed in sort of just over 3 months where a client came. We did exactly that. We introduced passive extension. Here was disc bulge. Seneca was gone. However, because people have problems with their active system, what their muscles are up to, if they've got a very particular imbalance between their glutes and say their psoas and their hip flexors, and you put them into that passive extension, you're going to start to fiddle with that slight anterior pelvic tilt or anterior pelvic tension, I prefer to call it. And that may make them worse because again, it might encourage those hip flexors and psoas to clamp on even more and their glutes to become even more lazy and even more inhibited. So again, we need a thorough assessment of the active system as well as the passive system to see what's really going on. And the way that we can do that is we can test you on certain movements and postures to see what your aggravators are. What are the things that tend to irritate you? And we can sort of work backwards from that and work out what your muscles have done in response to that injury. Because if you have an interesting issue we have to deal with, which is AMI, which is arthrogenic neuromuscular inhibition. Now this is a proven issue whereby we have damage or an injury to a joint. The neurological system, the body will change how the muscles around that joint behave. So a very sort of classic example is what we call glute inhibition system or lazy ass syndrome. Where we have injury to or pain around a hip joint, and the nervous system will actually inhibit or down tune the signal going to the glutes, the biggest, most important muscle around the joint that stabilizes it, to try and protect the joint from further injury. And while that's happening, it'll also clamp down on things like your psoas and your hip flexors, which will make the problem even worse because now the joint's even more imbalanced. And if you give that to somebody who's got chronic back issues, if they've got very weak glutes, that's more work on its own that goes into the lower back. If you then add the extra tension of the hip flexors and psoas kind of pulling you down and forward, that's even more work that the lower back's got to do. So again, we need to understand that if your back's sore, it's not weak, it's being overused, and it's the confusion or the lack of things doing their fair share of work around the hips and the core that's causing that pain, not just any possible mechanical damage like a disc bulge, herniation, end plate fracture, whatever it may be. So the solution is to have a thorough assessment where, yes, you can use an MRI as part of the assessment, but it is only part of the assessment. We also need to see what your muscles have done around the problem to give you an indication as to what's going on and what's causing your pain. Because quite often people have people that have mechanical damage to the passive system and the active system at the same time. Most of their pain usually comes from what the active system's done in response to their injury, not necessarily the mechanical damage to the passive tissues. So again, a thorough assessment is key. If you have not got access to someone that can do a thorough assessment for you to see what your muscles are up to, the other thing to look at is your pain patterns. So how does your pain change throughout the day, or how does it alternate between different days? If you keep a diary and have a look through, you'll start to see there'll be certain patterns, either around certain times of day, certain days we do certain tasks or positions more than others. And from that, it will start to give you a bit of an indicator. A good example of that, the very classic pain patterns, people that generally tend to feel worse in the morning. And generally it's a sign they've got hypermobility or an instability around their joints. And when they sleep at night, and that weights off our spine, our discs increase in height a little bit, but it makes us a little bit more unstable. So they'll say things like, oh, I feel very stiff and very like protective first thing in the morning. You know, if I step off an awkward curb or off an awkward surface, I'll get like a little catch of pain. That's a good sign that someone's got instability and they're missing certain stabilizing components that are not quite doing their job. Now, it could just be weak atrophied muscles like multifidus, for example, or it could literally be like a sequencing issue in their neurological component of their spinal stability that doesn't get the correct muscles to fire in the right way to stabilize the spine when it becomes unstable. But again, the only way to know is to have a thorough assessment. So, don't panic if the MRI looks normal and you've still got pain. You're not going mad. There will be something there. You're just going to find somebody or find a way of identifying what's going on in terms of your active neurological systems. And from those assessments and the MRI, you now have a complete picture of what the problem actually is. And from there, you'll be able to propose solutions to your problem.